Sir, should we wait for a while or should we start?
Sorry, I had just gone to wash my hands. Hanji, I'm with you. कितने लोग हैं? 215. Okay. This is going to be one of our last meetings. Next Wednesday onwards, we are meeting physically in the seminar room. Oh. You want to wait for a few minutes? How long will it take for the presentation, Chandrika?
Sir, around 30 to 40 minutes.
30 to 40 minutes. Okay, we can start then. It's already 2:15. Good. Is here, Vikram is here. Okay, Ankit, over to you. You're on mute.
So have all the PGs joined? I think Vikram has joined, Samiksha has joined. So I think you start, Chandrika, and there would be some people who would join, and we'll have some time for discussion as well. So over to you.
Okay, sir. Good afternoon, everyone. Today I'll be presenting the class on cystic fibrosis under the guidance of Dr. Ankit Parakh. Introduction. It is an autosomal recessive multisystem disorder. The primary defect is dysfunction of CFTR protein, that is cystic fibrosis transmembrane conductance protein. It is the major cause of severe chronic lung disease in children. It affects the epithelial cells of respiratory, GI, reproductive tracts, and leads to abnormal exocrine gland function. Coming to the genetics part, the CF gene is located on the long arm of chromosome 7, which codes for the CFTR protein. It is expressed in the epithelial cells of airways, GI tract, sweat glands, and genitourinary tract. Around 1900 CFTR polymorphisms have been reported. The most common mutation of CFTR is delta F508, that is deletion of a single phenylalanine residue at amino acid 508, which leads to absence or defective function of the CFTR protein. Inheritance pattern is autosomal recessive as shown in the pedigree chart. CFTR protein. The CFTR protein allows movement of chloride ions out of an epithelial cell into the airway surface liquid and mucus. The positively charged sodium ions follow passively, thus increasing the total electrolyte concentration in the mucus and resulting in the movement of water out of the cell via osmosis. The mucus is cleared by mucociliary clearance. Mucociliary clearance mechanism. It is the primary innate defense mechanism of the lung. The functional components are the protective mucus layer,
There is connectivity
airway
problem.
surface liquid
You're
layer,
losing your voice.
and the cilia on the surface of ciliated cells, waves to propel the pathogens and inhale. Okay, sir. I'll repeat it from this slide onwards.
Chandrika, there's a lot of disturbance from your side.
Yes, sir.
Connectivity is also not good. You are logged on via your phone or via the hospital Wi-Fi?
Sir, it's my phone only, but I'm in an ICU. Maybe because of that, the disturbance is there.
Hospital Wi-Fi नहीं है बेटा आपके पास?
Sir, internet connection is okay. I think it is disturbance from the noise. I'll go in another reading room. So, from where should I start again?
ठीक है, I think इसी slide से कर लो.
This slide.
Yeah, from this slide, previous slide.
Mucociliary clearance. This. Okay. Am I audible, sir, now? CFTR protein allows the movement of chloride ions out of an epithelial cell into the airway surface liquid and mucus. Positively charged sodium ions follow passively, increasing the total electrolyte concentration in the mucus and resulting in the movement of water out of cell via osmosis. This mucus is being cleared by mucociliary clearance. Mucociliary clearance. It is the primary innate defense mechanism of the lungs. The functional components are the protective mucus layer, the airway surface liquid, organelles that beat in waves to propel the pathogens and inhaled particles trapped in the mucus layer out of the airways. This picture shows normal CFTR channel versus mutant CFTR channel. As we can see, the chloride ions can be transported through the normal CFTR channel, but there is altered transport through the mutant channel, which results in dehydrated mucus secretions and thus impaired mucociliary clearance. Pathophysiology of the disease: mutant CFTR leading to altered chloride transport and decreased chloride secretion and increased sodium absorption, further leading to dehydrated and thick mucus secretions, leading to impaired mucociliary clearance and airway obstruction initiating from small airways. Thus, there is failure to clear inhaled bacteria and persistent chronic lung infections can be the presentation. The impaired mucociliary clearance further superimposes on the persistent lung infections, and the patients may present as bronchiolitis, bronchitis, bronchiolitis obliterans, and bronchiectasis further. Further, pulmonary manifestations of the disease as discussed are, they may remain asymptomatic in the first year of life. Initial symptom is cough, and with further progression, sputum, they may present as sputum production, exercise intolerance, shortness of breath, and failure to thrive. Also, chronic sinusitis and nasal polyposis may be the presentation in them. There will be frequent exacerbations requiring hospital admissions. On examination, there will be increased AP diameter of chest, hyperresonance, coarse crackles, or wheezing. Chest radiographs are suggestive of hyperinflation of lungs, non-specific peribronchial thickening, hilar lymph node prominence, nodular densities and infiltrates, depressed diaphragm, and narrow cardiac shadow, and further complicating to cyst formation and extensive bronchiectasis. The pulmonary function tests reveal gradual decline in FEV1, that is forced expiratory volume in 1 second, with every year. Increased residual volume and functional residual capacity. The microbiological studies of the secretions are suggest most common organism grown in them are Haemophilus influenzae, Staph aureus, Pseudomonas aeruginosa, Burkholderia capacia complex, Aspergillus fumigatus, and Mycobacterium avium complex. The pulmonary manifestations can further complicate to pneumothorax, hemoptysis, digital clubbing, cor pulmonale, and further respiratory failure. The slide shows the serial chest x-rays of a 9-year-old child with cystic fibrosis. In this, the chest x-ray in A block shows the bilateral hyperinflation of lungs, narrow cardiac shadow, and mild peribronchial thickening. Further, repeat serial x-rays as shown in B box. The chest x-ray shows increased peribronchial thickening, and further complicating to extensive involvement of the peribronchial thickening and mucus plugging during the exacerbation episode. Further, the X-ray shows bronchiectatic segments, but after the resolution of the exacerbation period. And the last X-ray shows widespread involvement and upper lobe involvement of the lungs with bronchiectatic segments. This is the CT chest of a patient with cystic fibrosis of 12-year-old, which is suggestive of bronchiectatic segments as shown, the dilated segments, as we can see, and mucus plugging also with the arrowheads. Coming to the GI manifestations, abdominal distension, emesis, and failure to pass meconium in first 1 to 2 days of life, which can present as meconium ileus and further complicating to meconium peritonitis. Neonatal jaundice also can be the presentation due to biliary obstruction, further to biliary cirrhosis and complicating to ascites, varices, or splenomegaly. In older children, it can present as cramping, abdominal pain, and distension, and which can be seen as distal intestinal obstruction syndrome. So X-ray abdomen will usually show dilated bowels, increased air fluid levels, ground glass material in the lower abdomen. This is the X-ray abdomen erect view of a neonate on day 3 of life, showing dilated bowels and absent gas shadow in the rectum with meconium ileus. Pancreas involvement, exocrine insufficiency can be seen because of the protein and fat malabsorption. There will be bulky and greasy stools, deficiency of fat-soluble vitamins, protuberant abdomen and decreased muscle mass, poor growth and failure to thrive. Endocrine insufficiency usually presents in the later stage of life, that is around second decade, and may manifest as diabetes mellitus and acute pancreatitis. Sweat glands involvement, excess loss of salt in sweat is seen, and during the episodes of gastroenteritis, this salt depletion gets aggravated. They usually present with hyponatremic, hypokalemic alkalosis and salt frosting on skin. Genitourinary tract involvement is usually less common compared to other systems, and it can present as azoospermia in males. So clinical presentation in infancy period, in sinopulmonary system, we can see as sinopulmonary infections such as sinusitis, bronchitis, bronchiolitis, bronchiectasis. And in GIT infancy period can be GI manifestation can be present as meconium ileus or rectal prolapse, and other involvement can be like dehydration episodes with hyponatremic, hypokalemic alkalosis. In childhood period, in respiratory system, they can present as allergic bronchopulmonary aspergillosis, sinusitis, and polyposis. And in GI manifestation, distal intestinal obstruction syndrome and intussusception. Further, other system involvement, renal calculi also can be there, and they will usually present with failure to thrive. In adolescent period, they will present with, they can present if the disease has further progressed to pneumothorax or respiratory failure, and the similar manifestation as the childhood. Along with this, in other systems, there can be delayed puberty, renal failure, and arthritis also. Newborn screening. It can be done by immunoreactive trypsinogen.
Chandrika, so I think all of our PGs need to know that how does a child with CF present. I think that is the most important thing. So
Yes.
just to clarify a few things there. So if you have an infant who presents with supposedly 3-4 episodes of wheeze or pneumonia, then what is your possible differential diagnosis, and what are the pointers which tells you that this is where you would like to screen this child for cystic fibrosis?
Yes, sir. So if the child is presenting with the multiple episodes of wheezing and chest infections, if other system involvement also, I can see like GI involvement or episodes of any dehydration or any according to age group also we can see. then we can approach the child for evaluation of
So,
cystic.
age at the moment, as I said, is infant. So, like a
Yes.
10-year-old child. So, would you evaluate for a CF?
No, so we can observe first, and if the severe, according to severity, also if they require hospital admission,
Okay.
if it also depends if they require hospital admission if the illness was so severe.
Okay. So, what else? So, my point is that. So, how will you practically? What are the practical pointers which tells you that this child might be having cystic fibrosis?
Any history of CF in any in sibling or family, then for
Create any history of CF in sibling, any death in the sibling, any consanguinity.
yes sir.
Okay, so these are definite markers. What else? So any of our PGs who are there?
So, child with the failure to thrive and requiring multiple admissions for the recurrent episode or recurrent wheezing and other symptom involvement. These are the conditions which can be think about
Vikram, your voice is cracking, not clear. So I think one thing which Vikram has brought up, and we all should remember, is that children with cystic fibrosis usually will have a lot of failure to thrive, and this failure to thrive is disproportionate to the amount of infections or disproportionate to the amount of hospital admissions or the number of episodes this child is having, right? So that is a very important marker which tells you that this child can have a CF, because these children have usually have, it is not always, but these children usually have associated malabsorption. It would be rare to see a child with CF who does not have malabsorption presenting to you with recurrent LRTIs. So that is something which is extremely important, right? So if a child has a very good growth, it is unlikely to be cystic fibrosis, because that tells you about the exocrine pancreatic insufficiency. Okay, what else? What else? There's something which is extremely important,
Sir,
and that is that.
every time child is requiring antibiotic therapy to resolve the symptoms.
Okay, but a lot of VZ children are also given antibiotics. So, what I would say is that a VZ child who is also wet, right? So, in general, CF does not present with pneumonias. It is an airway disease. It is not a parenchymal lung disease. So, what they present is recurrent LRTIs, which are not like typical pneumonias. They're like recurrent bronchitis sort of a thing. You will not find something great on the x-rays. You will not find usual consolidations. It is not like an immune deficiency, and they would be usually wet. So a wet cough which does not go is something which is sinister in a young child. Okay, so a wet child who may or may not be wheezy, has recurrent infections, not like typical pneumonias, looks like an airway disease, and has malabsorption. These are the main things which tells you and which can help you narrow down your differential diagnosis. ठीक है, Chandrika, I think you can continue.
Okay sir. So coming to the newborn screening, it can be done by the immunoreactive trypsinogen assay at birth by dried blood spot. It is considered as a positive screen if the IRT is elevated along with a single detected mutation. The positive screens are further followed by a sweat chloride analysis. In newborn period, sweat chloride analysis is only done after 36-week corrected gestational age, weight greater than 2 kg, or age greater than 10 days. Direct ion selective electrophoresis by pilocarpine stimulation. Sweat collection done by cellulose chromatography filter paper, and the elution from filter paper is done for 30 minutes. Collections below 1 gram per meter square per minute are considered as insufficient samples. False results can be there if there is inadequate sweat collection, poor methodology, poor operator techniques, misinterpretation, or improper sample collection. The procedure being shown in the figure as shown that the electrode is attached to the forearm, preferably right forearm, and the electrode drives the medicine into the skin, that is the pilocarpine. Pilocarpine stimulates the sweat glands, and the filter paper, that is the chromatography filter paper, that collects the sweat, and it is being tested for chloride concentration. So interpretation of sweat chloride levels is that if it is less than 30 milliequivalent per liter, CF is unlikely. 30 to 59, it is borderline and may be CF with atypical involvement. So there is a need to repeat the test. If more than or equal to 60 milliequivalent per liter, it is diagnostic of CF with one or more criteria. So approach will be any child with recurrent or persistent pneumonia or wheezing, malabsorption, and failure to thrive. Sweat chloride, whether sweat chloride testing facility is available or not. So if it is available, then we do the testing. And if it is less than 30, then CF is unlikely. 30 to 59, repeat sweat chloride, and if again borderline, then mutation analysis can be further done. If more than or equal to 60, repeat sweat chloride, and if again it is more than or equal to 60, treat it as CF. If no sweat chloride testing facility is available, then investigate further for serum electrolytes, ABG, respiratory secretions culture, stool microscopy. If they present with hyponatremia, hypokalemia, metabolic alkalosis, along with this organisms grown in respiratory secretion, fat globules present in stool, if all these findings are present, then follow up the patient and treat as cystic fibrosis. Diagnostic criteria of cystic fibrosis. If the presence of typical clinical features as discussed in the previous slides, which can be respiratory, GIT, or genitourinary symptom, or history of CF in a sibling, or positive newborn screening test. Any one of these plus lab evidence of 2 sweat chloride level more than or equal to 60 milliequivalent per liter on 2 separate days, or identification of 2 CF mutations by DNA testing, or abnormal nasal potential difference, which is obsolete these days. Exacerbations can present as increased frequency and duration of cough, increased sputum production, shortness of breath, decreased exercise tolerance. On examination, tachypnea with intercostal and subcostal retractions can be seen. On auscultation, rales and wheeze can be there. Fever, leukocytosis, and weight loss will be there, and X-ray chest will be suggestive of infiltrates. Coming to the management part, maintain the hydration, nutritional therapy, as discussed in the further slide, that high calorie diet should be given to promote adequate weight gain in such children. Pancreatic enzyme replacement. This reduces the fat and protein losses in the stool. Dosage is 3,000 to 5,000 units per kg per day. These are enteric coated enzymes which are pH sensitive, so mixed in small amount of acidic foods and given to the child. Vitamin and mineral supplements, that is fat soluble vitamins because of the fat loss in the stool, that is vitamin A, D, E, and K. Salt supplementation and diet. Pulmonary therapy, inhalational therapy, human recombinant DNAs as aerosol dose, 2.5 mg OD. This enzyme degrades the DNA of the neutrophils and extra and decreases the thickness of the mucus and decreases the viscosity of these secretions. And nebulization of hypertonic saline can be used because it hydrates the desiccated and thick mucus and thus improves the mucociliary clearance. Airway clearance therapy, in which which includes the chest physiotherapy and postural drainage 2 to 4 times a day. So various methods of the clearance are discussed here. That is percussion and postural drainage, in which we do the postural drainage, percussion and vibration of the chest. Positive expiratory pressure. Expiratory breathing against a pressure at 10 to 25 centimeter water to raise the functional residual capacity or to reinflate the collapsed lung. ACBT, that is active cycle of breathing. In this, we advise the patient to do thoracic expansion exercises, controlled breathing to aerate alveoli and distal airways, and to move the mucus to proximal airways. Post expiratory technique to clear secretions. Autogenic drainage, tidal breathing with controlled expiratory flow. Next is oscillatory positive expiratory pressure. Intermittently, we tell them to interrupt the expiratory flow and causing the air to vibrate. High frequency chest compression, pulses of pressure through inflatable compressive vest to vibrate the airways, which increase airflow at low lung volume and thus increase the mobilization of the sputum. Apart from this, regular vigorous exercises, aerobic as well as anaerobic training. Antibiotics, oral antibiotic therapy depending on the culture and sensitivity of the organisms, or aerosolized antibiotic therapy, in which we can use tobramycin, aerosolized tobramycin inhalation and aerosolized aztreonam inhalation. If on exacerbation, if not responding to oral antibiotic therapy, then we can use IV antibiotic therapy. Further, if presenting as severe episodes of severe asthma or exacerbation, bronchodilators or corticosteroids can be used. Ivacaftor, which is a CFTR modulator drug, it is the first available treatment which targets the defective CFTR protein. It facilitates the increased chloride transport by potentiating the opening of the chloride channels. Thank you.
Good and comprehensive presentation, Chandrika. Well done.
Thank you, sir.
Questions, comments by presidents? Ankit, would you like to?
So, Chandrika, supposingly you have a child with cystic fibrosis.
Yes, sir.
So, practically, what all would you give?
Practically, so based on the symptom profile. Okay. So, based on the symptom profile, if respiratory involvement is there, and
Stop sharing your screen.
what's it?
You can stop sharing your screen.
Okay, sir.
Okay. So, if you have a child with cystic fibrosis, then practically, आप क्या दोगे उसको? मतलब, what is the treatment, like a treatment chart, which you would do for the child?
Okay. So, first I will advise them to maintain hydration and have a high calorie diet, so the child does not suffer from failure to thrive.
Okay.
And further, vitamin and mineral supplementations will give.
Yeah. Vitamins and minerals, definitely yes. So at least 2 to 3 times the RDA is something which is recommended. So it is always to be done, including fat soluble vitamins, because when you have a fat malabsorption, the fat soluble vitamins they need to be replaced. So it is not just vitamin B, vitamin C. You have to look at vitamin A, vitamin D, and even vitamin K is something which is depleted, and vitamin E. So even vitamin E is given usually as, previously it used to be available as Evian drops. Now we don't get drops. So usually the capsule is used. You can puncture it and give it. Might be 200 alternate days is something what people usually would do, because पहले 25 units per ml आता था, but now it is not available. Okay, some people also give oral vitamin K. All people don't use that, but some people also use vitamin K. Okay, what else would you use?
So, pancreatic enzyme replacement, crayon capsule.
So pancreatic enzyme replacement has to be used. Usually it is given as 3,000 to 5,000 units per kg per day. and for the major meals, you give the largest parts for 2 or 3 meals, and for snacks you can use a very small part. It is important not to crush the granules, otherwise they're not working. You can mix it with jam or something, and can be given with meals. Okay, what else?
We need to train the parents about the physiotherapy, various chest physiotherapy.
Okay,
Really
great.
help.
So all children with cystic fibrosis, physiotherapy is something which has to be done, even if the child is asymptomatic. So that is something which we need to remember. Multivitamins and physiotherapy is something which has to be done for all children. If you have a malabsorption, clinically, some people do the fecal elastase, and look at fat malabsorption, because in very early parts of life you may not have an exocrine pancreatic insufficiency, or sometimes you have partial forms where the pancreas are not involved, then you may not have. So creon is plus minus, but yes, for most children. Okay, so physiotherapy, do you use anything with physiotherapy also?
Sir, nebulization of hypertonic saline.
So hypertonic saline is something which is a definite yes for all children symptomatic. They should be on hypertonic saline. What we have available with us is 3% hypertonic saline. In the Western world, they use 7% hypertonic saline. We don't have it, so we don't use it. But there's a lot of data which says that 7% is superior to 3%. Okay, so hypertonic saline is yes. Some people also prime children before giving hypertonic saline with salbutamol, because sometimes it can lead to bronchospasm. But if they're not having any problems prior to or after nebulization with hypertonic saline, then you always may not need to nebulize them. Okay, what else? So what physiotherapy you will advise parents?
Uh, Percussion and postural drainage usually, I
Okay,
think. And
okay, और जो
position
बाकी
changes.
आपने बाकी भी काफी चीजें बताई थी ना फिजियोथेरेपी
Yes,
के
sir.
लिए.
Yes, sir.
और प्रैक्टिकली क्या करोगे?
Sir, I have not seen these exercises, or I have seen postural drainage and percussion
So
exercises.
usually percussion and drainage is something which should be taught to all parents, right? So that is the baseline, and usually you don't need a physiotherapist for that. Obviously, large teams, for example, AIMS, even CMC Vellore, they have a physiotherapist who is a part of a CF team. Okay, and anywhere across the globe, if they are running a CF center or a CF clinic, then there would be a designated pediatric chest physiotherapist who is part of a CF team, who is going to see all patients and teach physiotherapy to parents. So that is a very important part, right? And how they run a CF clinic would be that they would have 4 rooms, and there would be 4 children who come in, and the children would be stationed in a room. They're not going across the room to meet the concerned person. Rather, the child with cystic fibrosis will be sitting in one room. So it will be seen by a consultant, it will be seen by a dietitian, it will be seen by a physiotherapist, and anyone else who is required as a part of the CF team. So the child does not go around, because there's a lot of chance of cross infections which can happen, especially in the hospital. Okay, now physiotherapy usually has to be done at least once a day if the child is well, the child does not have a wet cough, and the chest appears to be clear. Older children will usually require it twice a day. Okay, now how do you assess that physiotherapy is working? So you have to look at the
Decrease expectoration.
right. So it is not just expectoration, because a lot of young children will not be able to bring out the sputum, but that does not mean that they do not have secretions in the airway. See, even a 2 months old child with cystic fibrosis will have a lot of secretions in the airway, but still does not bring out sputum. So technically he is not productive. Okay, but still secretions are there. So that is where the concept of a wet cough comes in. that the child still has secretions, and it is the sound of the cough or the huff which tells you that this child has secretions in the airway. So anytime when a child with CF comes, we would ask the child to do a huff. So huff is something like this. Okay, and when they do a huff, you can make out the noise which is there in the airways, and that tells you whether the chest is dry or it is wet. Okay. So percussion is something which is taught to most parents. So usually with the palm, okay, with slightly fingers bent and movement at the wrist and not at the elbow is something which we teach them. Okay, and around 5 to 10 minutes at least is something which is to be done. Now, for older children, you can try things like sports is a very good modality which clears the chest. You can ask the parents, for example, for a young child like 2, 3 years, 4 years old, they can take a trampoline. So trampoline you must have seen in malls, बच्चे उस पर jump करते रहते हैं. Okay, so that is a very good exercise which is advised to parents. Just trampoline is something which is quite good. Okay, and for slightly older children, something which is quite good is to use an a cappella, which is easily available. And it definitely helps because older children don't want to be lie down and do percussion because वो ऐसा लगता है इसकी पिटाई कर रहे हैं लिटा के. So acapella is available easily. It is available from Smiths, that is the company which makes acapellas. It is available as blue and green. So blue, so you can use acapellas for children who have bronchiectasis. It is a PEP device. It is an oscillatory PEP, which you were talking about. Okay, a lot of countries do use vest, but they are quite expensive. So vest is basically the main advantage. What they cite is कि आपको उसमें कुछ करना नहीं है, आपने वेस्ट पहना, उसको ऑन किया और वो secretions जो हैं gradually they move around, and then you have to huff and take them out. The problem is it is extremely costly. So at least I have not seen a vest being used in India. Okay, so physiotherapy is definitely required for all patients. Okay, so what else would you do?
Investigate.
Okay, so also annual review. Okay, so annual reviews are basically done as a part of CF clinic, and usually there are protocols made that these are something which you would check. So you'll see the height, you'll see the weight, you'll look at the growth chart, the faltering of growth. Most people will do vitamin levels, including vitamin and rest of the vitamins as well. Okay, people do bone mineral densities as well. People do LFTs, sometimes even thyroid function and all these things to ascertain what's going on with the cystic fibrosis thing. The other thing which usually people would do is cuff swabs. Okay, so how is a cuff swab done? How is it different from a throat swab? So I think you must have sometime taken a cuff swab for a child with CF. किसने तो लिया होगा ओपीडी में, नहीं लिया? Okay, so basically what you do in a throat swab is to touch the posterior pharyngeal wall. Okay, rub it gently on the posterior pharyngeal wall, and the aim is to look at the microbial growth or the microorganisms in the throat. Now, what you want to do in a cuff swab is slightly different. You take the same swab stick, but now you're interested in the pathogens which are there in the lungs or in the sputum. But because this child cannot bring out sputum, so 3 years old, 4, 5 years old, this child is not bringing out sputum. So if the child can bring out sputum or an induced sputum, then there is no sense of doing a cuff swab. Okay, then you collect an induced sputum. But if the child cannot produce an induced sputum, then what you do is that you gently insert the swab stick near to the posterior pharyngeal, being careful that you don't touch it. Okay, and we want the child to cough. Now when the child coughs, there would be secretions which are going to get stuck on the swab stick, and that can be sent for a culture. Okay, so it is quite okay for bacterial pathogens. It is still not standardized for atypical mycobacteria, because atypical mycobacteria are something which can be there in children who presents with cystic fibrosis. For that, you need either a sputum or a bowel sample. So cough swabs are done to look at colonization. So they might be colonized with staph. Older children might be
We lost Ankit. Huh?
Yes, sir.
चंद्रिका कॉल कर लो अंकल को, अंकित को.
Yes, sir. मैं करती हूँ.